some of the more basic propositions and claims against GPs. I've put down the statistics for those of you that like reading statistics. You can bore yourself to sleep at night if you want. But to really illustrate two things. One, that GP claims are comparatively few when compared against other hospital setting negligence claims. And two, that the majority are of a lower value, which is obviously to be expected. We will then, in the main part of today, which we thought would be particularly fun and informative, is to run a mock clinic, which Simon will go through. We've put 4 scenarios down there, which you can see, but due to NHS pressures, the Charcot foot is not going to be discussed, but you still have the slides, or certainly will, and you can read through those at your leisure. So there'll be a clinic of back pain, cauda equina, bowel cancer, and potential meningitis. We'll then try and draw some conclusions together at the end, and hopefully have a bit of a discussion about whether or not the 3 instances that we discussed there have in fact been any negligence. So, as I said, I've put in the statistics from the most recent NHSR reports. I don't expect you to read all of these, but what they show very much, that you can see hopefully, is that the majority of claims by volume in the GP pathway settle for nil. When you contrast that, of course, to the other claims made against principally hospitals and secondary care, it shows that GP claims are a tiny fraction of the claims brought and dealt with by NHS resolution. When I was preparing this, I came across a really very interesting article, which I've included at the top there, which was written by Professor Hayward in the Medical Law Review, and it deals with an empirical study of reported cases on Westlaw, which I'll return to in a moment, or towards the end of the seminar. But as I say there on the second bullet point, it's very clear that the number of claims made against GPs is consistently lower than against other specialisms, and that the data does suggest that the GP's greatest exposure is in relation to inappropriate prescribing, or in relation to a lack or a failure to refer into secondary care. So that sets the scene. When you look at the data in more detail, it does show that there's an increase in the number of claims against GPs being made, but that it is lower. And against that backdrop, I'm going to ask Simon now to take over, and he's going to deal with a GP's approach before he gets on to deal with the mock clinic. Thank you.
You looked a bit stumbled there, sorry. Charles, thank you, and thank you everyone. Very nice to be here, and we're going to just run through firstly just a few thoughts about what it's like on the coalface in general practice. Charles has already alluded to the rise in claims, and there's that whole increase in the claim culture. General practice is very busy, it's very challenging. The resource we have is absurdly limited, as it is within the whole of the NHS. And general practice is very much a great example of Britain being a nation of shopkeepers, because every GP surgery essentially is a small independent business, but it's running to a contract with the NHS that's about 250 pages long, and there's loads and loads of other documents that dictate what else is going to happen. The funding is very, very small. You probably pay more for your pet insurance than your GP gets paid for your individual care. And the hours of work are quite long. The GP surgery is open for an extended day every day of the week. People obviously are aware of that appointment they have with the GP, that 10-minute appointment, but there's so many things that are happening, and those things that are happening are becoming more and more numerous. So you've got the home visit, which takes commuting time and the consultation time, with seeing the patient in the living room and then getting them to move through to the bedroom so you can examine them, and the preparation time to make sure you've adequately read the notes before you go, because you haven't got a copy of the notes or the records with you. You've got looking through the labs, the correspondence. There's a big long list on the screen. These days, because of the extended team, there's also the interruptions, or for want of a more polite phrase, from colleagues who come to ask for support and guidance and assistance. It all adds to the stress and the burden. GPs are often taking work home with them and doing stuff in the evening and finishing late, and they're working much more than one would see within that time frame. There's also a lot of clinical responsibility that's shifting from the hospital towards primary care, so treatment of the patient with high blood pressure, with COPD, with diabetes, and many more illnesses. It all adds to an incredibly complicated job and an incredibly big stress and burden, and somehow we have to try and do that safely, which all potentially means there's a bit more work for the legal profession, unfortunately. We're doing our best to avoid that because we don't want to have to meet you guys, but sometimes we possibly do. And the other thing is that the whole attitude of society might well be changing. The old stoical patient who might well have a opinion that the doctor's trying best and will be forgiving is moving towards a culture where if I wish to see a movie, I can just have it straight away on some streaming service in ultra high definition surround sound, as opposed to having to go down to the video shop to get it. We want things now, and also if we're not happy, we're used to putting reviews in places and saying we're not happy with it, so there's always that threat. The concept of I'll sue you, I want some compensation is certainly there. So we are very aware of that risk. And we're always thinking about how do I make sure that I deliver the best care, but we're also certainly now thinking about how do I make sure I document what I've been doing so I can make sure I've demonstrated I've done a good job should there be that complaint that comes through. Quality of care certainly improved, and I remember the introduction of NICE, and I remember the introduction of the clinical knowledge summaries. I remember the clinical knowledge summaries moving over to NICE, and that certainly plays true into general practice about being given some best practice guidance about what to do. I think it's certainly true that most, if not all, GPs will refer to those sorts of guidelines. In addition, there's lots and lots of other guidelines that are not just from places like NICE, although a lot of those will probably apply a lot more towards certain specialists and certain conditions to a much more fine level. But we've got instant access to information. That's often why the doctor is looking on the internet. They're not asking Dr. Google. They're looking for the expert guidance to make sure that they're doing things up to date. But medicine is difficult, and there's a reason why it takes us many years to become doctors, and there's a reason why it takes us many more years to become specialists, whether it be a specialist in a secondary care hospital field, or whether it be a specialist in primary care, family medicine, or general practice. And that's because there's lots and lots of nuanced things. It's not quite as simple as I have a cough, therefore I have a chest infection. Hopefully people appreciate that. But there's lots and lots of complexity, and within medicine, within general practice, we talk about the biopsychosocial model of health. And just to break that down really quickly, just to think about it, not only do we have perhaps an illness, a condition, a pathology, but the way that we think about that, the way that the fears and worries that we might have will impact upon the symptoms that gives us. And also our social environment will affect our recovery from that, or again our perceptions of that, or what we should be doing for it. So general practitioners are often balancing up all those complexities, the multiple symptoms, the multiple signs, all the investigations, and we're trying to figure that all out. And we sometimes use tools like ideas, concerns, expectations, ICE, as the acronym. So we'll often be asking patients, what do you think is going on? It's not us being stupid. It's us just trying to make sure that we're on the same page and we're addressing what some of those problems might be, the things that we don't quite know about. And then we're ultimately having to individualise care. And within the guidelines, within the NICE guidelines, you'll often see, if you're thinking about has the doctor done the right thing, because the guidelines say to do this, within the guidelines it's often talking about patient-centred care, offering patient-centred care. And that's kind of the euphemism to say that the doctor has personalised something, considering all the different conditions that could be going on, and considering what the patient is thinking and what they want. And the final flaw with guidelines is they are just guidelines. They're not the law. They haven't been handed down in tablets of stone. We are sometimes allowed to see a little bit off-piste on this because sometimes things don't quite precisely apply. And that's kind of, again, the complexity of medicine delivering healthcare, thinking about that personalised care. Also within general practice, again, that 10-minute construct, that 10-minute appointment, we can't do everything. And once someone leaves the room, we can't demand what happens. So patients have a choice as to what they do, and we can't control that at all. And we have to hand over responsibility once again to the patient. We might take on responsibility for organising an investigation, or for arranging a prescription, or for making a referral. But ultimately, there's also patient choices and what patients do outside that room. And things will happen, things will develop, things will change. So we often safety net. We'll describe things that might go wrong, things that you might need to be watching out for, what you might need to be doing if those certain things happen. We'll talk about red flags and we'll talk about safety netting. And once upon a time, we'll document it as, if the problem persists, come and see me again, as on Charles's slide. But these days you might notice in some notes a lot more detail about if ABC happens, then do X, Y, Z. And so that's really, really important to make sure that we educate, inform patients as what to do next. And then the final complexity, I think it was the final complexity in all of this, is that, again, we've still got the 10 minutes, and in all of that, we still haven't written anything down. So once a patient leaves the room, the doctor is probably then going to spend a few minutes documenting this all down to make sure that hopefully they keep themselves out of deep water. But that also sits all within that 10-minute time frame, and you never know what you need to document until you find out that you didn't document it. So, we do try our best, but we often slip into habits that we rely on, but we do need to try and make sure that we're documenting things adequately. And it's just basically quite a difficult job to juggle all these balls and spin all these plates and make sure that nothing falls to the floor whilst you're doing it. So, back to Charles before I think it's back onto one of my slides.
But there's a fair degree of chopping and changing. I think Simon has shown us there very succinctly the multitude of factors and thoughts that will have to go through a GP's head during a 10-minute consultation. It's extremely easy as lawyers, and I do appreciate this is our jobs, to be critical of what's happened or not happened in a 10-minute consultation. But you'll see when you read the case law, there's consistently time and time again the judges make the court aware and in their judgments that this has to be looked at through the pressures that a GP is facing, and I think that's reflected very much by the types of cases that find their way to actual reported decisions. Now, before we go on to the mock consultations, I wanted to specifically flag up the codes of practice from a legal perspective. So you've heard what Simon said from a clinical perspective, and everyone in this room, no doubt, will have used the NICE guidelines or the Royal College of Surgeons, Obstetricians guidelines, both to argue in favour of their point and to argue against the other side's point. So they really can be of great assistance. But when you find yourself confronted with a lawyer saying, well, you either have or haven't followed the NICE guidelines, the usual response is to say, certainly from the defendant's side, their guidelines, not tramlines. So I've just taken the opportunity to include a couple of cases where the guidelines have been discussed, and there's a particularly interesting dicta from Mr. Justice Wolfe, as he then was, who emphasises that whilst they are not conclusive, so that departure from their terms necessarily involves a breach of duty, and they are not rigid rules, they are very strong evidence as to what is the proper standard which should be adopted, and unless there is some justification, a departure from this will be regarded as constituting a breach of duty. And the key word there, of course, is justification, which links very much into what Simon was saying about documenting, as we'll come on to, your decision and how you would reach that. I came across the interesting decision in LT and Lothian NHS Board, which is a Scottish decision, but it is useful nonetheless, because I've certainly experienced this before, that the professional guidelines do not of themselves amount to evidence without an expert commenting on them. So it cannot be that counsel or the solicitor can say, well, you've not followed the guidelines for X, Y, or Z reason, without one of their experts actually supporting that proposition, and that was made clear in the Scottish decision of LT. So departing from the professional guidelines is always going to be the most risky, for want of a better description, practice for any medical professional. And it's always going to have to be, you have to justify why you are departing from them. And I wanted to emphasise 2 points really, which is the second and fourth bullet points. The case of R and Lanarkshire, again it's the Scottish decision, but it's interesting because that concerned a junior doctor taking the decision to depart from the guidelines, and the court emphasised that judgments about whether or not to depart from the guidelines had to be informed by the clinician's level of experience, and they were clear that where a junior clinician departs from the guidelines without consulting a senior colleague, that failure would more than likely result in a finding of negligence. So I thought that was particularly interesting, but certainly in a general practice setting, because of the nature of how busy they are, and whether or not a more senior colleague can easily be consulted within a 10-minute window. And then finally, the fourth bullet point. I'm sure most of you have had cases where the guidelines have been discussed with your experts, and the experts are critical of the guidelines and say, well, I don't actually think that's quite right. From a claimant's perspective, you have to be very careful, because obviously in light of Blythe, it would be exceptional for a court to conclude that a defendant was negligent if he complied with the relevant guidelines. Since whilst there could be professional disagreement about the content of such guidelines, it would be very difficult to demonstrate in such an instance that following the guideline was indeed illogical. So that comes with a word of caution for the claimant lawyers in the room, that if the defendants have complied with the guidelines, even if there's criticisms of the guidelines, it is going to be a difficult ask for you to persuade a judge, given what Blythe says. So hopefully that set the scene to you all. We want to move on for the remaining 40 minutes or so to deal with this mock clinic. And as I said, there's three patients who will be called forward from the GP waiting room. The first, I understand, is whose name I can't remember. Tommy Jones. So I'm going to remain here. If you, Tommy Jones, would join the doctor, please. The doctor is ready to see you now.
Mr. Jones, come and have a seat. Dr. Minkoff, sorry. Always taught to have a firm grip. Sorry about that. I understand, and you've just had a quick flick through your notes there, that you're 40 years old. Yeah, okay. How can I help today? I'm saying we'll know what's some notes. I've seen it beforehand. How can I help today?
I want some stronger painkillers for my back.
Yeah. What happened with your back?
Well, lifting at work 2 weeks ago just went. It's gone before. And what I usually do is I just take a bit of Counsel and just lie up for a couple of days, it's fine. It does not better this time. The Counsel is not doing any good. So I want some stronger painkillers so I can get back to work.
Okay. And just want to ask a few other questions just to make sure I'm clear about the back
Okay,
pain.
well, I'm going to get the painkillers.
Is it just pain in the back?
Yeah.
Yeah. Anything going down one leg or the other?
What do you mean?
Any pain and any numbness, tingling?
Well, it's a bit, nothing to worry about.
One side, both sides?
Just one leg.
Just one leg. Which one are we talking about?
Left.
Okay. And is that a tingling, numbness?
Yeah, a bit numb, but probably the painkillers,
Is it just in the leg?
Yeah, I think so.
Between the legs?
Yeah.
Not really. Okay. And any change in your toilet habit? Going to the toilet for wheeze or poos?
Well, when you take painkillers, it's not very good, is it? So, not that I've noticed, no.
Okay, good stuff. I just want to do a quick examination of you, pop your pouch, and just check sensation.
Okay.
I'm not going to do that right now for the room. And I'm also going to do just a little bit thing called a leg raise, and then we'll just have a little chat and then we've done that.
Okay.
Okay. And so I can't find anything strange on that examination, which is good to know. So what we'll do here is we'll give you some extra stronger painkillers, give you a stronger cocodamol, and some extra diazepam to use. What I'd like to do is just see you if that's not helping. Should be better within a week or so.
That'd be good, yeah.
Sound reasonable?
Get back to work,
Okay. Anything else I can do for you?
Don't think so, no.
All
Thanks.
right. Nice to meet you.
Thank you.
Okay.
You can go now.
Yeah, if you like. Right. There we go. I've typed up some notes for you, and you can see my notes on the screen there. What I'd like to know from any of you here, just have a little look at that, what your thoughts are about my consultation and my notes. Yes.
I was just wondering, like, you just gave him drugs because he was in pain, but you haven't found out why he was in pain and what caused it.
Okay, so repeat what you said, just in case we need to project to the people in the back and the audience. You just wanted, it was just prescription medicines and why we hadn't thought about what the diagnosis was, what the cause was. Anything else? Yes?
You question and try to exclude red flags, but you know it doesn't.
Okay, so I questioned, checked about red flags, but my notes don't say the same thing. Fantastic. Anything else? Oh, it's not fantastic, I did that. Fantastic, you noted it. Any other thoughts or observations there?
What about the examination?
You haven't said something where the examination was, so you've not said what tests you've done in the exam.
Yeah, I think the one that I would be doing significantly as a GP would be to do the straight leg raise, because that will help establish whether the sciatic nerve stretches. That's probably what most GPs will do. But what I've written just here is I've just written down lots of pain. I haven't actually written down even whether there was a straight leg raise test done and whether the findings were normal or not. So yeah. I'll run through a few other things there. So we've got the incomplete notes, we've got the poor examination, we've got the management plan, as you say, kind of missing out really what the problem is as to what the diagnosis is. The other thing is safety netting. What was my safety net? Would you say that was a safe, or do you think there's a little bit of risk there as well? I mean, it's a little bit, yeah.
You didn't like advise and get dangerous or anything to offend anyone, you just said I'll see you again in 2 weeks.
Yeah.
So you just sort of sent anything as well about safety net and activation.
It was a pretty weak, poor safety net. Just come back if it's not any better. Haven't described about any red flags. Not about missed the red flags anyway that he's described and that we found in examination. So this to me was meant to be a pretty poor management of some potential called recliner. We've got a few slides there, so we'll run through if that's okay. Yeah, and then we'll run on to the next patient. Ignore the length and complexity of these slides just to demonstrate a few things. I just pulled some stuff off the nice CKS website here. There's two different guidelines with regards to back pain, but the one that we're really worried about is the sciatica, the lumbar radiculopathy, where the nerves coming out the spine are affected. And the words in red are some of those symptoms we're looking for that are basically about red flags, which some of you have already spotted that I was asking if it's about. I just didn't document very well. So we're talking about the pain or the sensory sensations travelling further down the limb with symptoms such as paresthesia, which is basically pins and needles, weakness of the leg, straight leg raised test, you stretch the sciatic nerve and you cause the symptoms to be reproduced. Lots and lots of red flags mentioned in the NICE guidelines, but I think the ones in red are the ones that the GPs tend to be thinking about and tend to be really focused on, about the weakness, the saddle anaesthesia, the loss of sensation between the legs in the perineal area, and the bowel and bladder dysfunction, which actually is quite specific. It's where the bladder doesn't empty properly or the bowel doesn't hold things in properly. So it's quite specific what loss of function one gets with it. There we go, caught up. But there are other things that can be going on, and there are other significant things, because all we focused on there really is cause requirement. But in me taking a history, if I'm concerned that someone's got a fracture risk, for example, because of medications they're taking, because of an illness they have, because of their age, then I might be thinking that maybe, for example, they've had a spontaneous collapse of a vertebra in the back, which is causing these symptoms. And then if the patient's talking about some very, very acute sudden weight loss or other symptoms, I might be thinking, is this a new diagnosis of a cancer that has already spread, metastasized to the back? And then we can have things like various infections around the back. The one that I always remember is the spinal epidural abscess, partly because I used to do lots and lots of anaesthetics. It was always a risk that every time I popped a needle in someone's back, that might be a complication that arose thereafter. But there could be all sorts of reasons. So if someone's coming in with a fever and other kind of infection symptoms, you might be thinking this could be such an infection. And all of these conditions are very much emergencies or urgent referrals. We don't sit on them for weeks on end. Some of those we actually want the same day review by the specialist. And if you thought that was it, there's a load more. Big long list of different things that your doctor's going to be thinking of. And part of the beauty of general practice is, even though we have this awfully short 10-minute consultation, we can also see patients again and again. So sometimes that diagnostic journey is actually a series of consultations. So it might actually be 3 or 4 consultations until you actually get to the bottom of it. There's a little bit of an adage in general practice that if you've seen a patient 3 times, you're going to call for help, you're going to get a second opinion. So come half an hour of consulting time, if you haven't figured it out as a doctor, you're probably thinking, do I want them to see someone else in the surgery? Do I want to refer to a specialist because I'm just not getting on top of this? And that is probably to the relief of the patient as much as to the doctor when you get to that. But a big, massive, long list of things in there, and some significant things like pancreatitis will cause back pain. Things to do with the aorta will cause back pain. So there could be some very, very significant illnesses still sitting in that big long list Charles, over to you.
Thank you. So I've focused on cauda equina because it's as opposed to sciatica or other. Just to summarise this consultation, mainly because I think lawyers' eyes always light up when they see the words cauda equina, notwithstanding the difficulties. Now, the decision in Zaab is quite a well-known cauda equina case, and that was the judgment of Mr. Justice Tugendhat. And it's an interesting decision. I do recommend that you read it, where it's a patient suffering from bilateral sciatica, and the subsequently, of course, turned out to be cauda equina syndrome. The judge held that it was not negligent in failing to make an immediate referral to a neurosurgeon, and he did so on interesting grounds. He did so on the basis that, on the facts, the neurosurgeon would not have been negligent in not admitting the patient for surgery, and he said that it followed that a GP would not be negligent in failing to make a same-day referral, which that is a difficult decision really to follow. I don't know if anyone else has got some interesting thoughts about it. Okay. And tell me afterwards. Because obviously he's confusing breach of duty and causation. The breach is obviously a question for the GP on the basis of the evidence at the time of the consultation. He should not really rely upon whether or not a neurosurgeon would have been negligent further down the line. The case of Shaw as well, it's an interesting case based on the facts and the fact that the parties had agreed by their respective experts that if any red flags were present, a failure to immediately refer would be negligent, and that if there was a failure to warn about red flags developing and that there is a need to seek urgent medical attention if those red flags develop, would also constitute a breach of duty. Now, I've just included at the bottom, just as a bit of a food for thought kind of point, the approach that the Canadian courts have often take, and maybe Craig's got some interesting thoughts on this, so tell us about them afterwards, which is the principle of worst first, and the theory is that sort of the reverse of common things are common, that a diagnosis based upon probability is a flawed concept, and that you should approach it based upon severity. There's no such hard and fast rule in the English courts. It's based upon presentation at the time, but you can see that line of thinking creeping into a lot of cases with GPs, which is, and I'm sure you've all heard various experts say, oh, the golden rule of medicine is to rule out the serious pathology first, and that's effectively what the Canadians have adopted there. But whether or not it should apply, that's an interesting question, so you can all go away and think about that and let us know what your thoughts are. Okay, well, as receptionist to Dr. Minkoff, I'll call in the next patient, please, which is Bobby Brown.
Hi, Bobby, nice to meet you.
Hi, Bobby.
How are you today?
I'm okay. I'm a little bit worried, so I can see you today. I've started to lose a bit of weight.
Yeah.
Not really trying. I'm not going to the gym or anything. And I've not changed my diet.
You've lost some weight.
I've lost some weight, yeah.
Yeah.
My clothes are a little bit loose.
I think I pulled the wrong notes up. Just 1 minute.
There we go.
Sorry, that was me.
Secretary's
Hang on
fault.
a moment. Sorry, you should have said that you're not Bobby as you walked in. Sorry, so you lost a bit of weight, you've noticed?
I've lost a bit of weight, yeah.
How much have you gained? When did you first notice?
Probably about 6 weeks ago, maybe longer.
Anything else you've noticed?
A bit embarrassing, but I've got a little bit of blood in the loo. I've noticed some blood in the loo.
When you do a poo, doesn't it?
Yeah.
Okay. And is that kind of just on the toilet paper, or is that sitting in the pan?
No, it's in the pan.
Okay. Any tummy pain?
No, it's okay.
All right. Any change in appetite?
No, I'm still eating the same, really.
Okay. Anything in particular wrong with you about this?
Well, I'm losing weight. I don't think I need to lose weight, so I'd rather not. And I've got a family history of cancer. So I don't know what type of cancer, but some close family members have died in their 50s and 60s.
Who was that?
My uncle and my grandparents.
Uncle and grandparents. Okay.
Yeah.
Okay. Just a few other background questions. Do you smoke?
Not now. I gave up about 6 weeks ago.
Okay. How many years did you smoke for?
Since I was at uni.
Since you were at uni. How much did you
Long
smoke?
time. About 40 or 50 a day.
Okay. How's it going? Not smoking.
Oh, it struggled a bit, but I think it's the right thing to do at this age.
Well done, and hope you managed to stay off the cigarettes. It's tough. What about drinking alcohol?
Yeah, I drink a bit. Not much, I think other people must drink more than me, but I like a couple of glasses of a night when I'm making dinner, and I go out with friends on a Friday and Saturday, and we like Japanese whiskey, so we'll drink some of that then. So it's not too much. I wouldn't say it's too much.
Too much. A couple of drinks every night, and then there's also a bottle of whiskey shared with some friends.
On a Saturday. Every Saturday we do a whiskey club, so
Wow,
every
sounds
Saturday.
nice. Anything else?
No, I think
Seems better.
that's it.
Okay. Any medicines you take? You've got some nasal results.
I get heartburn.
Yeah.
Yeah,
Okay.
so
Has
that's
that
the only
changed at all?
thing. Not really, no. I think it's always been pretty bad, so
Okay. So you've had this change in your bowel habit. You've
Yeah.
lost some weight. There's
Yeah.
a family history of cancer. You're worried it's cancer. I think what we need to do next is we need to get a little test on your poo,
okay.
and we'll get that sorted out. And then based on the results,
Do we need to do that now?
we'll give you a little kit to do at home.
Okay.
But let's do it quite quickly.
Right.
And then based on the results of that, we can then decide what we do next. So once you've done that poo test and you've brought it back to surgery, I would like you to make an appointment for a week later. And we'll run through the results at that time and figure out what to do. Is that okay?
Yeah.
All right, nice to meet you.
Right, thank you.
All right, best type up some notes there. Okay. So, any thoughts about the consultation or the documentation there, or the plan? There might not be any, because this was not meant to be something as obvious as that. And I'll let you into what the issue is here. The guidelines for suspected lower bowel cancer have changed quite recently. And we now do that test unless, and they're quite complicated, the guidelines. This is the bit where doctors are probably going to look into Google if they haven't quite remembered it. And what I haven't done is I haven't examined the patient. Because if Eddie had a bit of a tummy mass or a mass on an internal examination, she'll be getting a referral straight away, not having the test done first. So this is basically a bit of a delayed referral situation, potentially. Otherwise, hopefully the notes are quite good, and I think the history takes a pretty good idea of some of the risk factors that were present for a potential cancer. So basically we're missing the examination. I think Eddie would still get referred. I think she's probably going to go and get the test done and not neglect that. She's going to get reviewed. It's just the referral is going to be late, and if there's a big mass palpable in the tummy, then how quick is that going to continue to develop? So there's potential delayed diagnosis. Does that make sense?
Does anyone have any other comments about the consultation or no?
Well, what about the alcohol history? I mean, I was always told, whatever the doctor was told, you double it. So like that case.
Oh, so there's different ways of, yeah, so are you saying, Charles, that if the patient says they drink 14 units a week, you probably double it, they're probably drinking 28 units a week?
Yeah.
Or are you saying that the definition of an alcoholic is somebody who drinks more than their doctor?
Yeah, well, that's certainly a well-known one, but no, I just would you actually, someone gives you a history like that, would you actually think it's probably a bit higher with that entrance you're thinking?
I think some people know how much alcohol they're drinking, and they're quite reliable witnesses to it,
Yeah.
and some people don't. And the point here is that what's documented in the notes, which might have been accurate a while ago, might not be accurate now. But that was just a bit of fun for the audience to demonstrate that sometimes people drink a bit more than maybe that might be admitted. The point of the case is very much to say that the guidelines do sometimes change and they do sometimes get complicated, and it was just to point out that there may be things missing within the notes, even though actually the notes are accurate to the and it was a deficiency in the fact that I didn't know or remember the detail of that particular guideline, and I didn't examine, and if I had examined I would have found a mass and I would have looked at the guideline and I would have said we're getting a referral straight away.
And you weren't thinking of anything else you're going to tell us this now?
I wasn't thinking of anything else.
Yeah. And it was just counsel or not?
I designed this case to be very simply a barn door. This patient needs a referral for a suspected cancer and needs it straight away, but I just slightly mismanaged it by thinking about the test. And the purpose of the test, we'll come to another slide in a moment. So lots and lots and lots of different things that can be symptoms associated with suspected lower GI cancer, and ignore the fact that I've left some in red because I've forgotten why I highlighted them in red. And the FIT test, saying FIT test is a bit like saying PIN number because the T stands for test, but the FIT test is a very, very fancy modern test for blood in the poo, and it's the actual quantity of blood discovered will determine whether the referral gets fast-tracked even more. So it enables the service to determine how quick someone's going to be seen. But the problem, as I said, with this case was I didn't pay attention to that bit in red, that this was a patient aged over 50 with, this was a patient with weight loss and rectal bleeding, and therefore it sits in there in the FIT test. But you don't delay referral if there is a strong concern, such as, for example, abdominal mass, and there are lots of little boxes within the guideline. It is complicated, but it's that very, very final bullet point that we just messed up on in this case. And over to Charles for a little thing about the law.
Thank you. So, as hard as I tried, I couldn't actually find a reported GP bowel cancer case. But the two that I've included are very helpful. They are indeed cancer cases, but it tends to be in GP cancer cases that, from a claimant's perspective, you're going to be thinking about it. This is such a serious pathology. The consequences for missing it could be and often are devastating. So it's the low threshold for referral. Now, the decision of official solicitor Allinson, that's a High Court decision where it was agreed, again by the medical experts, that there should be a low threshold for referral. In that instance, the claimant had a lump in her breast and that there was a failure to refer, and it was held to be negligent. But just contrast that, though, to the decision in Carter underneath, where the claimant thought she had a lump in her breast and said that she was suffering from pain, but no lump was found on examination, and the Court of Appeal agreed with the first instance judge that it was not a negligent case, and that the general practitioner was not obliged to refer for a specialist investigation where nothing potentially sinister had been found. So those two show quite a nice difference in approach. Is there a very low threshold, so low that there should be referral even in an instance where nothing sinister has been found, or not? I mean, I think, as is often the case, it will be fact specific. Just in relation to bowel cancer, my own experience of cases involving bowel cancer tend to focus on whether or not rectal bleeding or the blood present was explained or unexplained. And I think that's the question that you were getting at in relation to whether or not the blood was present on the toilet paper or otherwise. Is that fair?
Yes.
No, good. I'm glad. Right, the doctor will see the next patient now, please. Arthur Price.
It's Katie, actually. Hi there, Katie.
Hi, Doctor. Hi.
How can I help today?
Oh, gosh, I've had a terrible headache now for the last 2 days.
Yeah.
And it's just making me feel awful. So I've taken some paracetamol, I've taken some more plus, but oh God, I feel terribly dizzy, I feel terribly sick. So I've stopped taking all that because I think I must be allergic to that now.
Is the dizziness and sickness after you take the medicine?
Yes, I just feel very dizzy and very sick.
Can I ask you a few questions about that headache?
Yes, you may.
So, is it there all the time? Does it come and go?
Oh no, it's constantly there. My head is just, I've got a lot of university work to get through as well.
Right.
I've not been in for the last 2 days. I just can't move.
Have you noticed anything else, like any change in your vision or?
No, my vision's okay. I just feel so dizzy and so sick and so tired. My friend brought me today. I've just got no energy left.
Oh dear. What about fever? Have you got a fever?
I do feel quite warm, yes.
Okay.
I just feel sleepy. I just don't want to move. And I'm in my dark, dingy university flat, and I just feel warm.
What's wrong with that? Dark and
Oh,
dingy?
it's just, I've got a terrible landlord. It's just not up to standard.
Oh dear.
It's dreadful.
It's dreadful. Okay. So anything you've got about what this headache might be?
Well, I don't know. Well, actually, in the halls down the road, there's been some reported cases that there's meningitis going on. Perhaps I've got that. It's in the halls down the road though, so maybe. I don't know. I'm just terribly distressed by all of this.
Okay. Do you know anybody who lives in the halls, Katie?
No.
No. You've been down to the halls like in parties?
No, but these things just get around, don't they?
All right. How are your vaccinations? Have you had all your vaccines?
Oh, no, none of them.
No.
No, I've had one of them.
Okay. Just a couple of things. We'll just do a quick examination of this. All right. Can I ask you to see a lot in your head? Can you put your chin down to your chest? You get any further down? Okay. And look up to the ceiling. And let's look straight ahead at me again. And just look here. Turn your head all the way out to the wall and all the way around to the audience. Okay. Fantastic. What are you hoping I can do today?
I'd just like some medications to make me feel better.
All right. I'm a little bit worried, Katie, about some of what you say,
Okay.
and I'm thinking perhaps maybe we need to get you seen an A&E department.
Oh, goodness me.
You've got a bit of fever, you're feeling really tired, you've got this constant headache.
Yeah.
So I'm wondering whether we should get you down to the hospital A&E department. Do you think we can get that organised?
Oh, yes. Oh, gosh, yes. This is a worry, isn't it?
Is your friend still here?
Outside,
Do you think
yes.
they'll give you a lift down?
Oh, I think so, yes. But this isn't great news. Am I going to be okay?
I hope so. I think going to hospital is the right thing to do.
All right.
Otherwise, the answer might not be.
Oh, goodness
Okay.
me. Oh, this is
Let's get that sorted out. Nice to meet you, Katie. All
Thanks
right.
very much, and I'll be back.
You'll all be pleased to hear that Katie made it.
So I best type a load of notes up there. Those notes are going to get turned into a little electronic letter, which Katie's going to take with her to the hospital. First, before I tell you my thoughts about the case, what are your thoughts, everyone? Yes.
I feel like she's just stressed over her uni work and she just let them down.
Okay, fantastic. So, differential diagnosis, us doctors talk about, different things it could be. So, stress run down university student, fantastic. Could be. Any other thoughts?
Did you ask about the severity of the headache?
A little bit, but I just wanted to whiz on for avoiding dragging on, because these can drag on. Thinking about headaches, and we'll get onto that. But it was you were describing, Katie, it was a very, very bad headache, and it was really stopping you doing things. I was getting a feel that this was very bad. Any other thoughts about what was going on with this case? What did I maybe miss out if we were thinking about serious headaches here? Katie's thinking, is this meningitis, for example?
Could it be a brain tumour?
It could be, but headaches with brain tumours, we classically learn, they tend to wake you up in the morning, and actually brain tumours don't tend to present with headaches first. New diagnosis brain tumours are often presenting as first seizure in A&E.
Okay, sorry, hemorrhage.
Was there a trauma?
So yeah, you can have hemorrhage, you can have subarachnoid hemorrhages. We talk about that as a thunderclap headache. It suddenly happened, but this has been for a few days. Now it could be that it suddenly happened and it's been going on for a few days. So yes, that is something to think about. If we're thinking meningitis, because that's what Katie's worried about, we've asked about fever. We know that she's quite tired and lethargic. We know she's got this headache. I asked her to move her head up and down, left and right. She had good neck movement.
Light sensitivity.
Light sensitivity. Rashes. I didn't ask about rash. And I haven't documented about a rash. So that one's missing. That worries me a little bit in terms of the quality of that consultation. The problem with headache is that it's really, really difficult. Headache is kind of my nemesis. There's so many different causes, and I'm going to quickly move on some of those slides there. So there's so much it could be, and like Charles was saying, sometimes you want to think about the serious things first. So all that stuff in the bottom in red, they're the things that the patients are often worrying about, and they're the things that I'm worrying about. Although I might also be thinking that Katie, with her dingy flat, might be having carbon monoxide poisoning as a cause of headache, although Katie might not be aware of that one. We could be thinking about subarachnoid hemorrhages, like Charles says in the audience. Acute closure glaucoma with a red eye and a painful eye is also an emergency, but that's going to tend to, we didn't ask about and look and comment on any eye changes. Giant cell arteritis, you get some pain relating to the vessels, the blood vessels on the outside of the head. Meningitis we all know about, becoming rarer, less common with the vaccinations, so that was a little extra clue in the history that she might be more at risk. Space-occupying lesion, fancy way of describing a brain tumour, and strokes can also present with. But in reality, most headaches actually are at the top of the list. They're not the red ones. The migraines, the cluster headaches, the stressed out students, the neck pain, medication overuse. I forgot to ask you about how much caffeine you drink, Katie, but caffeine and caffeine overuse can cause headaches, as much as too much paracetamol use and too much ibuprofen use and lots of other medications can cause it. Sinusitis and infection in the bones, and TMJ disorders. Some people actually get really, really painful jaws and it starts to cause a headache. There's so many causes and it can take so long to work your way through all the history to find it out. I struggle to deal with a headache in 10 minutes, to be utterly honest with you. So sometimes it is a matter of just trying to pick your way through it consultation by consultation. But really, I think the patient wants to make sure it's not something bad, and we also want to make sure it's not something bad. So lots and lots of things that I can take on history and on examination. Socrates is a fancy way of doctors remembering how to think about what's going on. So what's the site, what's the onset, what's the, I forgot what Socrates stands for, it's fantastic. It's stage fright. The character, whether it radiates, anything that is associated with it, the timing of it, anything that makes it better or worse, either exacerbating, and severity of it. So it's just a mnemonic, it doesn't kick in the stage fright, to do things. But there's lots and lots of things in that list that you can find. Again, you can understand when you start to think about that list, how it can take a bit more than 10 minutes to really properly deal with a headache. Charles?
Well, the doctor's finished his clinic now, he's off to play golf. I've just included the decision of McDonald in relation to meningitis, and I think this really does sum up, certainly meningitis, but a lot of GP cases, which is the aggregate set of symptoms and signs which could exist, even if they can be individually capable of being assessed as non-indicative of meningococcal infection. A doctor should consider whether, by reason of their aggregated presence or their totality, when taking the general condition of the child, a decision not to refer. And I mean, I don't know if any of you have got any ongoing meningitis cases, but it is the sudden onset of symptoms, the deterioration, and that usually every sign or symptom can be explained in isolation, but taking them together, I'm sure the doctor will correct me if I'm wrong, is the red flag really in those cases. Right, we're doing very well on time. So just conclusions, and I said that we'd come back to this empirical study which I found. So it's a little bit out of date, but it is very interesting. It's well worth a read. So it was all reported decisions on Westlaw between the 13th of November 97 to the 13th of November 2017. The reason they went from November 2097 is because of the decision that from Blytho came in. And some cases were discounted because they were inappropriate. For example, there was a few where the GP had sexually assaulted a patient, and that's why the litigation had been brought. But the results are really quite striking, and probably what most of you would have thought they would be anyway, which is that in the vast majority of successful claims, they related to a misdiagnosis or an inappropriate subsequent referral to hospital. And that really is the biggest factor that I think should be taken from this seminar, is that obviously there's lots of other claims that can be brought against GPs, but the ones that we tend to see most frequently are the ones where there's been poor examination, poor history taking, and therefore the referral that should have been made has not been made. And as I put there on the final bullet point, history, examination, documentation, can the decision be justified? That obviously relates to the guidelines. Has the patient been safety netted? Has the GP considered the serious pathology and ruled it out on a credible basis? Has the GP considered the totality of the claimant's symptoms? Those are the points which I think can be distilled down when approaching a GP case, and whether or not you want to run it, or whether or not you think you should be defending it. So just before we conclude then, right, the first case of, the name escapes me, who thinks it was negligent? Hands up. Come on, don't be shy. It's a pretty obvious one, this. That's very clearly negligent.
So can I just ask a question? Do you think that one that the GP should have been thinking border requirement, or just safety nets?
I personally would like to think that every time someone comes in to see me with first episode of back pain, that, like Charles says, I'll be thinking about those serious things first, and therefore thinking about whether this is called requirement. And I kind of was, but I just dropped it. I didn't deal with it, did I? I knew about the sciatic symptoms down the leg, but I just gave in to you and gave you the painkillers and sent you on your merry way.
That was appreciated. What I was really asking was, do you think he should have gone to hospital straight away
There should have been some more aggressive management by the doctor, yeah. I think, in order to respond to the symptoms of sciatica and to take those seriously. And instead, the doctor did not seem to appreciate and respond to those.
Still
Can I
think
ask
it's
a question?
negligent.
Sorry. Sorry, Sean. Yes, can I ask a question about because it's interesting is the bilateral sciatica was obviously considered one of the red flags, but I consistently get inconsistent evidence, let me say that, from GP experts about whether bilateral sciatica on its own is of itself a red flag, or whether that, because it's quite a common presentation, needs to be accompanied by other red flags before it then becomes a mandated referral red flag.
I'm not sure the right answer to that. I know from my own practice that any true sciatica, as opposed to someone describing a bit of pain going down the leg, but when you actually explore it a bit more and you realise that it is true sciatica, whether it's one leg or both, it still worries me. Think about what the pathology might be. If it's affecting both sides, it's going to be more significant. But I'm still going to manage it probably equally aggressively one way or the other.
So from your practice, if an individual presented with one red flag, would you refer? Or would you wait for multiple red flags?
No, one.
Yeah, that's good.
Any of them.
Any other comments on the back pain quarter recliner case? No. What about the bowel cancer case? Who would take that case on?
Take it on as a defendant or as a plaintiff?
Well, who'd run it? The defendants don't really have much say if it's being run.
Well, I think it's
Yeah, I
no examination.
who thinks it was a negligent consultation? Why, Helen?
I think you should have examined it and the symptoms were indicative to the cancer referral. But you then said the guidelines had changed because it was acceptable to do the fit test. But I think it's too much reliance based on the patient.
I think you're kind of demonstrating here the confusion of the whole changing guidelines,
Yeah.
because the guidelines talk about doing a fit test for a certain constellation of symptoms, but as soon as you've got the mass,
Yeah.
then you go straight to referral. So the guidelines just say, what do you do if there isn't a mass? But the fact that the doctor didn't examine, as you say, that's where the problem was. And like I say, even though the referral is still going to happen, it's the delayed referral and the implication of the delayed referral in potential prognosis. And so you're probably going to be getting that second opinion from an expert to say, what was the implication of this referral being delayed 2 weeks, 4 weeks, 6 weeks, whatever it was.
Sorry, just on that,
How
would
do you
you...
rely on how do you know how long that test will take, for example? I'm just very uncomfortable with the concept of sending the patient away to do a test when they were presenting with classic symptoms.
Okay, so that then starts to get to the expert who understands about why these thresholds have all been set for these suspected cancer referrals. But the point is to say that if you've got those symptoms and a mass, then it needs an even more urgent referral. It's kind of risk stratifying how quickly that referral happens. They're still going to be seen, but that fit test, as I said, is going to stratify people into the fit test is normal, and then you actually do it the wrong way around. The fit test is above a certain threshold, therefore, and they therefore get a referral, but that referral gets prioritised in the hospital. The fit test is below a threshold, they still get a referral, but they might have to wait a bit longer. And then the fit test, there is nothing measurable, but then it's down to the doctor's discretion. So even if there's nothing measurable in that patient, I'm still going to say, I'm still worried about this person. Yeah, I think they give me a very good history, and there's weight loss, and there's blood loss, and there's family history. I'm not going to take that risk on my shoulders and say it's probably okay. I'm going to say, despite the fact the fit test is normal, I still have clinical concern, and that sits in the guidelines as well. There's still clinical concern. That's my concern, not the patient's concern. If I'm still worried that this might be cancer, then I say, you still see them, please. So it's very, very confusing. And that's why I'm saying it might lead to some increased work for you, because that confusion will lead to some people perhaps kind of being managed on the wrong side of the pathway.
And you
through
didn't
genuine
explain that
human
question.
error and confusion.
Yeah, but that wasn't explained to the patient. Yeah, I don't think the patient understood the significance of
Well, we
that fit
said,
test as
we said get the test done,
That's
and as
fair.
soon as you've done the test, I went to book in because I want to see you one way or another. Because partly because I was still going to make that referral, it was just, and I wanted to make sure that there wasn't any uncertainty in the room that that referral was going to happen, because we were going to meet again and talk about what to do next. But the point of the case was I didn't examine, and therefore the referral was delayed. I didn't follow the guidance, and there was no reason not to follow the guidance. There wasn't a good reason to go off piste here.
If, let's just say you speak to the patient either on the phone or in the clinic, and she hadn't done the test a week later or whatever, what would you do then? You're just still worried
I think
about
the
how
guidance
it's,
still says I can still make a referral
Yeah.
and say I'm worried and concerned, if I remember correctly.
My concern on that, and I know that from the life point, if we're following NICE, we seem to be on safe ground. I'd be really concerned on that because you said that regardless, even if it came back with a low or a zero, you'd still refer her. And so my defensive attitude would be, well, you're not going to get over the hurdle that following the guidance was logical on the basis that you've accepted that you would have referred anywhere when she came back, so why are we wasting time doing the test? That would be my mission.
Because the test is there to enable the hospital to prioritise the referrals. So they're going to say this person's going to come in and see us very urgently because that fit test is very high, or less urgently because it's quite low, and it's to do with how NICE work out what the it's all about a 3% risk.
It's always a triaging process.
It is. So in a way that, like I say, the decision to refer is almost certainly being made. It's just, but that wasn't exactly the whole point of the case. So we're slightly going off message. The point of the case was I didn't examine the patient, and therefore I didn't do the right thing according to the guidelines.
well, we're lawyers, we like to all right, so sorry, who thought that one was negligent then? Sorry, hands up. All right, and then the final case, the headache. Who thought that was a negligent consultation?
I did, yeah. Should be examined for a rash at least.
Yeah, I think so.
Pretty rubbish doctor, aren't
Yeah, Helen, you've got a question.
well, there's more an observation, and you did make referral to A&E, but you didn't ask some very relevant questions. For example, sudden onset. You didn't ask, was it a sudden onset, which is classic SAH. And so some of the information in your referral letter might not have been as thorough as it could have been.
I absolutely agree. It was a very weak and thin history. I made the referral just to A&E to try and avoid having a conversation about that risk of what happens next. I didn't safety net it. I had lots of other thoughts in my head as to what it could be. The purpose of the very I was just clearly I was just fed up and frustrated at the end of my surgery, running very late, and that was the easy way for me just to close the case down safely, because the patient's still going to get seen, and if there was something urgent, it's probably not going to come back to bite me because she's being referred to the right place. But you're right, I might get a snotty letter from the A&E department to say you didn't really assess this patient very well. They had a stress headache, as you identified.
Good. Any other questions or comments? Okay. Well, thank you all very much for coming. I hope you found it interesting. As I said, this is a growing area, mainly, as Simon said, because of the amount of work that is now being placed upon GPs. It's only getting more and more, and it's more likely going to increase further still. And that leads to new challenges to GPs, but we can see, certainly I think, when you look at the cases, the real areas that GPs struggle with in terms of winning or losing a case. So I hope, as I say, you've all found it interesting. We were going to go and have a drink, so please all feel free to join us. I'm not quite sure where.
We're just gonna, there's just a program going.
Great.
If anyone wants to hang around, please join. If not, any action on
Yeah, so those that want to have a drink and tell the doctor about his consultations, please do so. Otherwise, enjoy the rest of your evening and thank you very much indeed.